But what for me, I guess social workers, there's a degree that you can get, MSW, which is what me and your sister have,
Okay.
Masters in Social Welfare or Social Work. And with that degree, I guess you can be called a social worker. But after you graduate from your master's program, you have to collect hours. He's interviewing me. It's really weird. You have to collect hours.
Great.
I forgot how many, like 3,200 hours or something.
Whoa.
And
that's a lot of hours.
There's like the California Behavioral, BBS, Behavioral Board of Sciences. You can Google that. Is the kind of the agency that oversees these professions. And after you collect your hours and you submit the proper documentation, you have to take all these other classes too. Then you could take a test, and then you become licensed.
Okay.
So it's just a process. It's not like so much.
So it's just an additional step for social workers to become
be licensed.
Yeah.
And once you're licensed, you have like continuing education credits, just like with doctors and things like that. With any of these fields, you need continuing education credits, like to renew your license every year.
Okay.
You're held to standards of law and ethics.
Okay, yeah, you pretty much answered my second question with that first answer, which was what type of education is required for this profession.
Oh, okay. So yeah, like Masters of Social Work. But if there's a lot of different counselors, so just because I'm an MSW and a licensed clinical social worker, I can do the same, like a marriage and family therapist. In our position, there's so many different types of licenses that people could have to do the same therapy.
Okay.
So.
Okay. In this profession, what kind of disabilities do you normally encounter?
First of all, I don't like the word disabilities.
I know it's a very negative term, but disorders or
mental health issues.
Obstacles, yes, obstacles.
Mental health. What's your question
again? What are the normal mental health issues that you encounter normally in this profession?
Well, because I work with probation kids, I think a lot of kids are labeled as like disruptive, oppositional, defiant, or conduct disorder, but for the most part, underlining all the disruptive behaviors is trauma.
Okay.
But I think, it ranges. I think we've had kids with ADHD, we have kids with anxiety, depression, but in adolescents and teens, kids are often like misdiagnosed with like ADHD or even disruptive and conduct disorder when they have underlying anxiety and depression. Because in depression, you think like adults, and the stereotype of depression is what, like
stay in bed, don't get out there, tired, sad with the world.
Yeah, but with teens and adolescents, it can look more like irritability, anger, for both like depression and anxiety. So it looks different, which people misdiagnose that oftentimes and think they're just disruptive kids, but underlining. And same with trauma, like a lot of trauma, kids, there's so much going on in their lives and they can't focus, they can't sit still, and people often get misdiagnosed with like ADHD instead of treating the underlying trauma that has been going on in their lives.
Okay. Alrighty. That is quite a handful right there. Okay. So screening for mental health concerns, is it part of the client's initial processing when they come into your organization, or is it done at someone's request, like the core probation officer or yourself?
For my programs, we get all our referrals from the probation department.
Okay.
And so the PO or the court will make a referral well, the referral's made by the probation officer, but the court might order it. So that's how we get all our referrals.
Okay. And does the client request to be screened, or is it usually the probation officer / court?
Actually, sometimes when the probation officers interview the kids and they share some of their own background, their own struggles, some clients do request that they want counseling services, and some families especially, also feel like, they want the services and support to help them in the process.
Okay.
So.
Alrighty. That's eye-opening. So how do you go about conducting these assessments when you're trying to diagnose? Are they similar to how you would assess an adult?
Yeah, I think like the assessment process, whether it's with kids or adults, you definitely have to build engagement. In the first meeting, we always go over the consents, the rights that the clients have. The services, even though they are referred by their probation officer, it's still voluntary, technically, for them. It's part of their right.
Okay.
They don't have to. It's kind of voluntold, I guess. Because if they don't participate, I guess that reflects badly on their probation if it's part of their orders.
Okay.
But we do an assessment, and the tool that we use in our agency and is required by Santa Clara County Behavioral Health is this tool called CANS. It's Child and Adolescent Needs and Strength. And it's a very comprehensive assessment where you help with the clients and families. You identify their areas of strength, you identify their areas of need. So you go through like all these different, it's not a question, it's more of a conversation, really building that relationship and getting to know the clients, like talents and interests, their strengths, internal, external, the family community strengths, and then like the emotional behavioral needs. So like if there's like anxiety, depression, psychosis, oppositional conduct, anger issues, things like that.
Okay.
Risk behaviors, you want to ask about substance use, you want to ask about aggression, suicide ideation, self-harm, runaway behaviors, any high-risk sexualized behaviors, anything and everything. Like, we assess fully, even if it's not applicable for what they were referred to, because sometimes you'll find even if they weren't referred to something, they still have this behavior. Some of the less common ones, like we still assess for like fire setting and things like that, but it's fully comprehensive, assessing their like needs, risk behaviors, their family history, family background, dynamics, anything and everything, and how it impacts their life. Like, that's the most important, because to have medical necessity, which means like you need to have, like, just because someone has depression, they could be really high functioning, right?
Yes.
And like nothing is, they're doing well in school, they're doing well in something else, with work. But for these kids, in order for them to meet like the diagnosis, part of the diagnosis criteria is that they have to have an impairment in functioning where their symptoms are causing significant distress
Okay.
in their life.
All right. Okay. So once you get your diagnosis, when creating a treatment plan, do you follow like a general template for each kind of disorder, and modify it as you go along with it, or do you just create an individual plan from the start?
Treatment plans are individualized. So with the assessment process, like, we identify the 2s and the 3s in the areas of need that you want to focus on. And with that, you talk to the client and the family to create the goals. Sometimes depending on their stage of change. So like, if they use substances, but they don't think it's a problem,
Okay.
then you have to kind of work and start where the client is at. Because if they don't think it's a problem, then they're not also motivated to work on it in treatment.
Okay.
You have to create goals that align with where they're at. So it is different for every client. Some clients, like for the most part, since we're a probation program, they just want to get it over with, just get off probation, and so that's their motivation.
Okay.
But we try to talk to them, okay, so what does that take for you to get off probation? And do a little bit motivational interviewing is, I guess, the technique that we, when they're in like a pre-contemplative stage of change and they don't think that what they're doing is a problem in their life.
All right.
I don't know if I answered your
You did.
question.
It's a very individualized process that I got from it. Are there any frequent challenges that get in the way of your client's treatment plan? Example: substance abuse, family court system.
Yeah, there's definitely, I mean, especially with probation kids, sometimes they can be really hard to get a hold of. So inconsistent engagement or barriers to engagement is pretty common. A lot of them have truancy issues, school refusal, they don't go to school as well. And it's rooted, I think, in a lot of times, like even from elementary school. So we have them as teenagers, but they've had negative experiences with the school system since they were young. Sometimes too, I think in mental health, our perspective, change takes a long time. But the courts and the judges want change to happen much faster than, is realistic.
Okay.
So they expect results right away, and that's also a barrier because then the court system might utilize like kind of the consequences and the threats. But it's not in alignment with like treatment, for example, even like substance use, right? If they expect them. Nowadays, I think some of the court systems, they have like a specialized mental health and drug court that is more understanding and not expecting results right away.
Okay.
So
It's progressing.
a little bit, although I don't like that court very much because they also hold very little accountability to the clients.
Ooh.
So there does need to be a balance, and some probation officers are really collaborative, and others, it depends on their understanding of mental health too, how much we can collaborate with them. But working with different probation officers is always a challenge. Working in school systems is a huge challenge. Because school systems are also, like I mentioned, like some of the kids can have really negative experiences.
Yes.
But yeah, I was with a client, I did an intake in Morgan Hill, and the family was sharing how, I don't know, they even said, I think once you're labeled too, once you start getting into trouble, then you're consistently like labeled by teachers, by principals.
Even when they improve themselves and they're trying to be better, they're consistently held to that label.
They're like, what did she say? Like, they called her and said, and her son wasn't meeting like, I don't know, some expectation, and something as simple as like he wasn't walking. He was walking too slow.
Wow.
To and from class. I don't know, but our it's really hard. Also, when like judges want them to be in school, but every school doesn't want our kids, and they get suspended, they get expelled, and so move from one school to the next, and they blow through all the schools, and none of the schools know how to handle and manage these kids' emotional behavioral needs. So
Okay.
it's hard to work in that.
I did not realize there's so many obstacles and these training kids are getting the treatment they deserve. Okay. So most literature say medication is considered a last resort for treatment by many health professionals. At what point do you yourself consider medication as the only real form of treatment for a client?
I would never say that medication's the only real form.
Well, does well, like as a last resort of any real form of treatment for a patient. That's what I meant.
Or what?
Also, most people, I'm saying most mental health professionals consider medications a last resort. They want to, try non-medication means of treating their patient, but when all else fails, they resort to medication. So for yourself, when do you resort to medication as your, last form of trying to get treatment for your client?
Well, as social workers and therapists, licensed social workers or therapists, we're not the ones that prescribe the medication. We would support our clients to get assessed by, you have to get assessed by a psychiatrist, and they're the ones that can prescribe it.
Okay.
But I think it really depends on the client. Some clients request it and are open to medication and wanting to try that because they know themselves and have maybe had past counseling experiences and feel it hasn't been helpful.
Okay.
But it really depends. People get medication for anxiety, for depression, for ADHD. I think I told you we did have some clients with bipolar or schizoaffective disorders. So I think especially with bipolar and schizophrenia, that definitely medication is really helpful in addition to therapy. But when it gets to like severe mental illness,
Okay.
medication is helpful.
All right.
But it depends, on the client.
Okay. Okay. So how long do you? I feel like you kind of answered this a little bit, but how long do you usually work with a client to ensure that their treatment plan is working?
Well, our timeline is we aren't able in our program. There's another program within our agency that's like outpatient therapy services, but our program is tied to probation. So if they get dismissed from probation, then they're also discharged from our program. But we work with them as long as we can and support them towards their goals. Sometimes it does take a really long time. Like I said, if there's barriers to engagement, like there's this client that we've been open for more than 6 months, but because he hasn't really been meeting with us, there hasn't been any progress on his goals.
Okay.
But like we wouldn't, just because of that, we wouldn't stop working with them. We would have to kind of explore like how to better build our engagement and relationship with the client, because that's number one, the most important. Like no matter what treatment that you give, 70% of outcomes is due to like your therapeutic alliance and relationship.
Okay.
So that's the most important thing, is if you have a strong relationship with your client, then you have a higher chance of better outcomes too.
Okay. So this might it's good. It's gonna get a little bit personal, but how do you classify where you've been successful or not with a client?
By the way, you spelled that wrong. Whether.
My bad. I apologize. Spell check failed me.
Mm-hmm.
So this is the last question. So feel free to go crazy on this one.
Well, it's hard to, I guess, determine what is successful and define what is success. I think we always have to report data and outcomes to the county as well, for program evaluation purposes, like both internal and external program evaluation, to see how we're doing. A lot of the times, like people evaluate, I think a lot of programs, especially with like dealing with probation, whether juvenile or adult, they look at recidivism. So whether or not the kid has another charge, gets detained again, fails probation, maybe gets transferred to adult court. But I think in mental health fields, especially within the juvenile justice system and in foster care system, I mean, the odds are stacked against these kids and families, and you can't really define success based on just these status outcomes, whether or not they reoffended, but more. I mean, I think I always encourage like myself and my staff to see the little successes, the
Okay.
little moments, where I recently, one of my staff is telling me how her kid right now is like actually just hospitalized. He was removed from the home as well, but his dad has always been like the traditional machismo type,
Understood.
like men don't cry and
Don't
his
show any
re-
emotion.
don't show emotion. His relationship with his son is very strained. His son is a very more emotional, like sensitive type of guy, and he's more tough love. And I think with that, their relationship has been a little bit tough too. But his dad has gone through a lot of his own like past trauma, and his dad was in the system as well. But with everything happening recently, because the kid got removed and hospitalized and everything, my staff was talking to him, and he said she was encouraging him, and like she knows like his machismo type of attitude, but she was always encouraging him like it's okay to cry, right? Like encouraging him to like process through his emotions, and he was like no, like men don't cry and whatnot. But the next day, and it took a long time. I think we've had him for we've known him for at least a year.
Okay.
Yeah. And the relationship with dad, our relationship with dad has also been like on and off. But I think she did a great job in building that relationship. But he called her the next day and he was like crying. And he said, like, you told me it was okay to cry, like, so I'm crying. And for me, I was like, you should highlight that as a success. I know in the midst of all the chaos, like it's hard, to find hope for these families, but it is those little moments and the little moments of change that you can't really define on a number
Okay.
of what success is. So even for a kid to kind of share some insight and realize like this is the reason why I've been doing it, or we've seen kids, I think like do really well, graduate from high school and all that, and that all feels successful too. But success is how you define these little moments. I think even if they get transferred to adult court, the relationship that you build, if we built a strong relationship, I would say that's pretty successful too, because I think with a lot of these kids, and they've had so much trauma and disruption and attachment issues, that the work in therapy is really that relationship, and changing like their internal working model about themselves, like they've been labeled as a bad kid or this and that, and if they can start to shift their thinking around it, or they always had a guard up and they never trusted anyone, but because of the relationship that you guys have built, like I would say it's pretty successful too.
Knock down some of those barriers.
Huh?
Knock down some of those barriers.
Yeah, and change their outlook on the world too, even if they continue. Yeah.
All right. Yeah, I mean, the more I study psychology, the more I see this is a gray area in human health. It's not like other physical illness where you have a disease or you don't, or you are injured or you're now cured. Mental health is just like it's a very big gray area of how would you define if they're better or not?
Yeah. Oh, other barriers to treatment.
Okay.
Parents, like family generational trauma.
Okay.
Like it's so hard to work with families because there's so much And that's the reason why you have to work from like a family systems perspective, not just the child, because the child's not the problem, right?
It's a combination.
There's generational trauma, there's cultural oppression, and so there's like system factors like poverty, racism that impact these communities of color, and most of our kids, right? The kids of color are disproportionately funneled into the juvenile justice system when they've been through so much trauma. They get, instead of getting the help they need, they get caught up with crimes and then they get the help.
Oh, okay.
Rather than, it would have been nice if there was preventative services to address some of the issues that they've had. And gangs, that's also a huge, like, it's really hard, like, for the kids that are really entrenched in gangs. It's hard to pull away from that lifestyle.
All right. Thank you, Ms. Lin, for your time. Those were all the questions I had. You were very informative. I have a completely new outlook at social work. Thank you. I will edit that out of the transcript. That last comment. But
I thought you're not recording. I'm not sending this in.
No, I'm not. This helps me when I type it. Keep it like the mindset. Don't worry. I assure you, this is not getting sent to my professor. But thank you for your time.
Better not. You're actually gonna type a transcript out?
I mean, no, it's a narrative. Like I gotta write like a narrative. So like. We talked, we cried, I don't know, just like write as a narrative.
We didn't cry.
But like, she just basically doesn't want to like be question answer. She wants to be like, how do you guys opened up? How did you guys start your conversation? Like, we started talking. She started sharing some facts. We then moved on to,
What does your assignment say?
Here you go. You want to see it?